Should I start the presentation, sir? Then you're able to see my screen, na, sir? Yes. Yes. Okay, sir. My patient, sir,
Trial.
she is a 32-year-old female, farmer by occupation, resident of Telangana, presenting with chief complaints of epigastric
Trial.
pain and vomiting since 6 months. History of present illness. Patient was apparently asymptomatic 6 months back when she developed epigastric pain, which is mild, continuous, dull aching type, intermittently colicky. It is aggravated by
Trial.
fasting and relieved by food intake. Sir, I'm able to have my own echo, sir. Hello.
Trial.
And the pain is mild, continuous, dull aching
Trial.
type, intermittently colicky. It is aggravated by fasting, relieved by food intake. There is no radiation to back or right shoulder.
Trial.
No change in posture, not associated or relieved by vomitings, for which initially she took some over-the-counter medications and had partial relief. She gives history of occasional vomitings once or twice a week, which is non-projectile,
Trial.
non-bilious, not associated with retching, and contains food particles taken in the immediate vicinity. Occasional coffee ground appearance is positive in the vomiting,
Trial.
which is small quantity. It is not associated with frank upper GI bleed, not associated with giddiness, syncopal attacks, or blood transfusions.
Trial.
Occasionally, she gives history of melena also during the episodes of coffee ground appearance. History of
Trial.
hepatitis is positive. She gives loss of weight of around 11 kgs in last 6 months. Initially, she was 66 kgs and now she is 55 kgs. History of loss of appetite is positive, but she doesn't give any history of dyspepsia,
Trial.
bloating sensation, heartburn, reflux, or regurgitation. There's no history of dysphagia, no
Trial.
history of giddiness, weakness, syncopal attacks, or blood transfusions, no history of lump abdomen or abdominal fullness. There is no history of jaundice. There's no history of back pain or bone pains, no history of abdomen distension or constipation,
Trial.
no history of chronic dust use or painkiller abuse. Past history.
Trial.
Patient doesn't have any comorbidities. She has undergone one LSCS in the past. There is no history of similar complaints in the past or long-standing history of acid peptic disease or gastroesophageal reflux disease.
Trial.
Personal history, she doesn't have any addictions. She consumes mixed diet. Sleep is normal. Bowel bladder habits are normal, and there is no known allergies. Family history is nil significant. Treatment history. For the same patient, I
Trial.
went to a local hospital, underwent an endoscopic procedure, and was told she has stomach cancer. After further evaluation, she received 4 cycles of chemotherapy. Last cycle was 6 weeks back.
Trial.
Patient had symptomatic improvement after chemotherapy. Her appetite has improved. She has had weight gain, and now she is 59 kgs, and she is tolerating adequate diet, and she is not
Trial.
having any vomitings or GI bleed presently. To summarize my history,
Trial.
sir, may I summarize my history, sir? My patient is a 32-year-old female
Trial.
with no comorbidities, presenting with history of epigastric pain and occasional non-bilious vomitings in 6 months, associated with occasional
Trial.
hematosis and melena, along with early satiety, significant loss of weight, and loss of appetite. She was diagnosed to have stomach
Trial.
cancer for the same and received 4 cycles of chemotherapy, last dose of which was 6 weeks back, to which she had good symptomatic improvement. So my differential, I would put a case because she already has a history of chemotherapy.
Trial.
My case would be a carcinoma stomach, probably locally advanced post neoadjuvant chemotherapy, to which he had good response. But still, I would also like to consider
Trial.
the G junction, though she is not having any history of dysphagia. And I would also like to have a third very
Trial.
rare differential of gastric lymphomas. Yes, sir. Yes. Sir, if that history is not there, sir, because she is a young female, my first differentiates to hello. Sir, because she is a young female, sir, but still because she is having significant loss of weight, loss of appetite, my first differentiate would still be carcinoma stomach, sir. But I would also consider benign gastric outlet obstruction or probably chronic acid peptic disease, and I would also because she is giving his hello. Because she's giving history of upper GI bleed and melena also, I would also consider just in my differential, sir, gastric cyst or lymphoma. Hello. Yes, sir. Even benign is because she's having this symptoms in 6 months, sir. Previously, she's denying. One thing in the pain that I would like to mention, sir, she's typically giving history that the pain is aggravated by fasting and relieved by food intake, sir. If I'm suspecting a malignancy patient, it would be the opposite way, sir. This type of a pain
Trial.
character is generally seen in acid peptic disease patients, sir, especially duodenal ulcer disease. And the patient is giving intermittent
Trial.
episodes of colic abdomen pain. She is giving history of upper GI bleed that can be because of erosive gastritis or a duodenal ulcer, sir. And
Trial.
loss of weight and loss of appetite that the patient is giving history can also be because of gastric outlet obstruction, poor intake, or because of the blood loss, sir.
Trial.
Yes, sir.
Trial. Trial.
The screen keeps telling trials, sir, continuously.
Trial.
Hello? Hello? Are we audible now?
Yes, sir. Now in the laptop also you're audible.
You're audible now, right?
Okay.
Yes, yes,
Okay.
please continue.
So I'll disconnect the
Can
phone,
we
sir.
put the phone off? No.
Yes, yes.
Right. Usual or a difficult situation for you because he's young, he's 30 years old. And
Sir, should I re-summarize my sir?
You can hear me now?
Yes, sir. I'm able to hear you, sir.
Okay. Say this is a difficult because he's a young patient, 32 years old, and it would be very difficult to make diagnosis of pregnancy unless there is a history. In the 11, which is a significant weight.
Your voice is actually breaking. Probably the net has
Gaurang, you can hear me now? इसी इसकी सेटिंग
नहीं सर ये आवाज आ रही है Gaurang, can you hear us? Hello, Gaurang, just check na if you can hear us. I'll disconnect the phone.
okay, sir. Or I can mute my laptop and just do it here, sir. Maybe you can try that.
No, but we want others also to
Listen,
be able to
I have
hear.
put the phone on loudspeaker now, sir. So I think they should be able to hear.
Okay, try. Give it a try. Give it a try.
Sir, is everyone able to hear us now, sir? Can we talk to any of the
Can somebody please respond whether you are able to hear both of us, Gaurang and me?
Yes, sir.
Okay. Good.
Yes, sir. We can hear you both.
Good,
Okay,
good.
so we will continue this.
Yeah. So sorry. So what I was saying that this is a difficult situation for you both in the exam and clinical practice because 32-year-old lady, it is very difficult to make a first diagnosis of malignancy. You have to be very, very careful. But
Yes, sir.
there is a strong and definite documented weight loss of 11 kg, which is definitely significant.
Yes, sir.
So it would be very difficult to explain this weight loss, especially if it is associated with anorexia by
Yes,
a benign diagnosis.
Yes, sir.
There are certain benign conditions where patients can have significant weight loss, but that is usually without anorexia. They would
Yes,
include dysphagia, for example, corrosive or peptic stricture of the esophagus, benign gastric outlet obstruction, proximal small bowel obstruction where patient is not able to tolerate even liquids, chronic pancreatitis, some medical conditions like diabetes, thyrotoxicosis, where in spite of a normal or even an increased appetite, there may be significant weight loss.
Yes, sir.
Now, so if you say benign diagnosis, what benign diagnosis you would like to entertain here?
Chronic acid peptic disease, sir, or chronic gastritis, sir.
But does she have symptoms to suggest that?
Beyond 6 months, she is not giving history, sir. But during the 6 months, the pain character that she is defining is looking a little bit like an acid peptic disease.
And how do you explain the weight loss with chronic gastritis or acid dyspeptic disease?
Because of poor oral intake, she may have, sir, not that significant, sir, but decreased intake and vomitings that she is having, and anemia can lead to some weight loss, sir.
But if I remember correctly, you said that the pain was aggravated by fasting and relieved by food.
Yes, sir.
So that is in contradiction. If
Yes,
the patient is having pain on fasting and the pain is relieved by food, the patient will eat more, especially if there is anorexia.
Yes, sir.
Isn't it?
Yes,
so without gastric outlet obstruction, it is very, very unlikely that the patient will have so much decreased intake as to cause 11 kg weight loss.
Yes, sir.
Another condition which I forgot to mention, benign condition which can cause significant weight loss is chronic mesenteric ischemia, where there is a definite history that intake of food precipitates the pain. So for the fear of food being precipitated by pain, the patient may reduce the oral intake. But then if you take a careful history, the patient would say that he or she wants to eat but doesn't eat because it precipitates pain.
Yes, sir.
So in such situations, your history has to be very detailed and very specific, whether it is loss of appetite or whether it is fear of taking food,
yes, sir,
which is causing decreased intake, isn't it?
Yes, sir.
Now, you did mention lymphoma as a possibility.
Yes, sir. As a so less probably, sir, but because she's receiving cyclical chemotherapy, sir. But
no, let us ignore that history of chemotherapy.
Yes, sir. Yes, sir. If we ignore the history of chemotherapy, my first different among the non. The voice is echoing. Hello.
Yes, I can hear you. Yes.
Yes, sir. Then if the history of chemotherapy is not there, sir, then my third differentiate would be a non benign gastric condition, sir, or gastric lymphoma, just versus or lymphoma, sir.
So see, lymphoma is usually not a clinical diagnosis. Lymphoma is usually a radiological or endoscopic or histological diagnosis. Only situation where you can and you should mention lymphoma in your clinical diagnosis is something like here, where there is a very young patient and all the features are suggestive of malignancy. So you can say that the history is highly suggestive of malignancy, but she's too young for an adenocarcinoma of the stomach, and that is why I would think of lymphoma. Otherwise, lymphoma comes in your mind or in your differential diagnosis when you see diffuse involvement of a viscous, when you see uniform, regular, circumferential thickening of a viscous on imaging, when with a clinical suspicion or an endoscopic suspicion of adenocarcinoma, your biopsy is negative, even your repeat biopsy is negative, and before that, when on endoscopy, the mucosa looks normal. So, young patient, history suggestive of malignancy, imaging like CT scan shows diffuse circumferential thickening of the wall of the stomach. You do an endoscopy, mucosa looks normal, your biopsies repeatedly are negative. That is where you start suspecting a lymphoma. Okay.
Yes. So here my intent of adding lymphoma is because she was having very good improvement with chemotherapy, sir. She repeatedly keeps telling that she is now totally normal. She is able to take good diet. She's having weight gain and all that. So I had included.
Agreed. Young patient, strong suspicion of malignancy, good response to chemotherapy are points in favor of lymphoma. I would take your argument on that. Now, you also mentioned GIST.
Yes, sir.
Why GIST?
So against a young patient presenting with epigastric pain and upper GI bleeding, sir, with a relatively preserved
she's not relatively preserved. She's lost 11 out of 55 kg. That's more than 20%. So GIST usually is not associated with anorexia and weight loss. Patient can have anorexia, and that also is actually not anorexia. It is early satiety if it is a large GIST, which is reducing the capacity of the stomach. GIST which is projecting more into the lumen rather than outside. But the common garden GIST, the classical presentation is actually painless bleeding. Patient may not even have pain. So the classical presentation is obvious GI bleed, hematemesis or melena, or features of anemia and a palpable lump. Pain, anorexia, and weight loss are much less common in GIST as compared to adenocarcinoma of the stomach.
Yes, sir.
Okay, let's proceed since we have wasted a lot of time in this.
Yes, sir. Proceeding with the examination, sir. General examination is fair. Patient is conscious, coherent, and cooperative. Well-oriented to time, place, and person. Moderately built and nourished. There is no palar, icterus, sinuses, clubbing, pulmonary pedal edema, or generalized lymphadenopathy. Left supraclavicular node is
As a
not
general
palpable.
rule, sorry, as
Her
a general
performance
rule,
status is
avoid using terms, generic terms like general condition is fair.
okay.
I don't think any textbook describes what is a fair, good, or excellent, or poor general condition. So be specific. If you are referring to nutritional status, describe nutritional status, that there are no features of. Here it is important because she's lost 11 out of 55 kg. So
Yes,
you have to carefully look for pedal edema, loss of subcutaneous fat, loss of fat in the zygomatic area, loss of supraclavicular fat, all these things, and vitamin deficiencies.
yes, sir.
So before you say no pallor, no pedal edema in a patient who's lost 11 kg weight, you have to be very, very careful.
Yes, sir.
Yes.
Her ECOG performance status is 1, sir. She's able to do her daily activities. Her BMI is 22. Breath holding time is 25 seconds. Her vitals are stable. Systemic examination is unremarkable. Mouth and oral cavity, no significant abnormalities detected. Per abdominal examination.
Why did you specifically examine the mouth and oral cavity? Anything?
Sir, not in this case, sir. If it was an esophageal or upper, then I would. Here I'm more looking for just some general signs like dehydration or any oral cavity lesion.
So then mention it as dehydration or no features of vitamin deficiency like
Yes.
angular stomatitis or chelosis.
Yes, sir. Yes, sir. For abdomen examination, inspection, abdomen is flat, umbilicus is central, there are no nodules, all quadrants moving correspondingly with respiration. There is no fullness or upper abdomen or visible peristalsis. There are no engorged veins. Previous Panelstein scar positive, which is healthy. Palpation, there is no local rise of temperature or tenderness, no mass palpable, no hepatosplenomegaly, inguinal orifices and franks are clean. Percussion, no free fluid in the abdomen, liver span from fifth intercostal space to costal margin in the mid-clavicular line, which measures around 12 centimeters. Ausculta percussion test, lower border of the stomach is seen, greater curvature 1 centimeter above the umbilicus, normal bowel sounds heard. For rectal examination, perineal skin is healthy, tone is normal, there is no mass, no Bubblema shelf palpable, gloved fingers stained with normal stools. To summarize after my examination.
Yeah, so it's more or less the same because we don't have any significant findings on examination, isn't it?
No, sir. She's just a well-preserved lady, sir, with no signs of gastric outlet obstruction or metastasis.
Yeah, so you are making actually two contradictory statements. On one hand, you are saying that she lost 11 kg.
Actually, sir, presently, post-chemotherapy, she is...
Yes. You said she has gained weight. Okay. I take that. Yes. Let's move on to what would you do? Suppose she came to you at that time before she started on chemotherapy. What would you have done?
Sir, pre-chemotherapy, sir?
Yes.
I would like to evaluate the patient first, sir, with a routine investigation because she is giving history of bleeding, hematemesis, marina. I would like to know her hemoglobin, her electrolytes, if she's having any dyselectrolytic. I would like to look for her LFT, to look for her albumin, any hypoalbuminemia. And then I would like to get one.
See, actually, in clinical practice, albumin is part of LFT, but here you are not looking at the LFT. You are looking at the nutritional status. So you are not concerned about the enzymes. You are not concerned about the bilirubin, unless you are thinking of nodes in the hepatoduodenal ligament or porta hepatis causing biliary obstruction. But that is not the aim. So you should say that I would like to evaluate her hemoglobin level and her nutritional status in the form of serum albumin. Those are the important. And because she's been vomiting, you would like to look at her renal functions and electrolytes. So be very specific. Here, when
Yes.
we are looking at albumin, it is not as a part of LFT. It is as a part
Yes.
of a nutritional parameter.
Yes, sir.
Let's see the reports.
Her hemoglobin is 11.7, sir. Platelets are 2.3 lakhs. Counts are 7,000.
But is this now or is this at that time?
No, sir. Pre-chemotherapy, sir.
This is pre-chemotherapy. Okay. Yeah.
Her renal functions are normal. Urea is 22, creatinine is 0.9. Electrolytes are okay. Sodium is 137, so potassium is 3.9, and chlorides are 105.
So whenever you describe a report which is being shown, you don't have to say both the things. Either you say renal functions are normal or you say urea is so much and creatinine is so much. Because
Okay.
at this level, we expect that if you say renal functions are normal, you know what is normal urea and creatinine. And the values
Yes.
are anyway there. So you don't have to read them out.
Yes, sir. Her albumin is normal, sir. There is no hypoalbuminemia. 4.2.
So
INR is coagulation profile.
do these reports tally with the history? Because this you are saying is pre-chemotherapy. At that time, she had lost 11 kg weight. You expect a person who has lost 11 kg weight to have a hemoglobin of 11 and a serum albumin of 4 point something?
Actually, no, sir, but she is giving only history of intermittent JB, sir. Probably it is not that. No history of any central attacks or generalized weakness. No history of blood transfusions.
And what about agreed that blood loss was not significant because it was just some ooze, coffee ground vomitus, and some melena. What about serum albumin of 4 point something in a patient who has lost 11 kg weight? Unlikely. So what can be a possible explanation?
Either she's not quantifying her weight loss properly, sir.
Okay, but she said that she has lost from this to this,
yes,
so that means that she has weighed herself.
Yes, sir.
Although you should have questioned that why did she weigh her when she was normal? Normally, you don't expect a farmer to weigh himself or herself when he or she is normal. So you have to be very careful and ask. Second possible explanation is dehydration, chronic dehydration. Most of our patients with GI malignancies, they will have chronic dehydration, and this all may be hemoconcentration. The hematocrit will be high, and once you hydrate them, all these values will drop down. Okay? These may be false elevated or false high levels of hemoglobin and serum albumin. Yes, carry on.
Her coagulation profile is normal, sir.
Yes.
I have got the coagulation profile done because I want to plan an endoscopy, sir, which may require taking biopsy, sir. Then I would proceed with an endoscopy, sir, to look for the lesion, the site of the lesion, the extent of the lesion, and to take adequate biopsy, sir.
Yeah. So as I have said in earlier classes, also by and large, there will be some exceptions. If your clinical suspicion is of a GI disorder, esophagus, stomach, duodenum, colon, rectum, then usually the first investigation is an endoscopy.
Yes, sir.
If your clinical suspicion is of a HPB disorder, then usually the first investigation is an ultrasound.
Yes, sir.
Okay. Yeah.
Yes, sir.
Let's see the endoscopy.
This is the pre-chemotherapy endoscopy, sir, which is showing a large ulcerated, infiltrative, excavated, friable growth in the incisure of the stomach in the body. There is no gastric outlet obstruction. D1, D2 is normal. Multiple biopsies have been taken for histopathology.
Are you happy with the endoscopy report?
No, sir. Two things I would also like to know, sir. I would like to know the distensibility of the stomach, sir, and I would like to know the extent of the lesion, sir. What is the proximal extent of the lesions?
Why do you want to? Yeah. Why do you want to know the distensibility of the stomach in a patient where they have described fundus normal, antrum normal, body also there is a growth at the incisura?
Yes. So because she is a young female, sir, in such patients, if we are anticipating a malignancy, it is more of a Laurent diffuse type, sir, which may present as a linitis plastica.
But is the endoscopy picture suggestive of a linitis plastica growth?
No, sir. It is more looking like a localized
so
growth,
how and when do you suspect linitis plastica on endoscopy?
Sir, when the stomach is not distending, sir. The mucosa is looking normal, but the stomach is not distending well. There is just diffuse thickening of the mucosa.
Yeah, so there are two or three features which suggest you that it could be Linitis plastica. One is that it is a diffuse, extensive involvement of the stomach. Here,
Yes, sir.
even the picture shows that rest of the stomach is normal. There is a lesion at one place. So this is
Yes, sir.
unlikely, although localized
Yes,
Linitis plastica is also known, but
Yes, sir.
generally it is a diffuse involvement. Second is
Yes,
that the mucosa usually looks normal. When you have a suspicion of malignancy and mucosa looks normal, one
Yes, sir.
possibility we said lymphoma, other is a Linitis plastica. And
Yes, sir.
third is as you rightly said, the distensibility of the stomach. In both conditions, both Linitis as well as in lymphoma, the stomach will not be distensible and
Yes.
its capacity is reduced. So this endoscopic picture is not suggestive of Linitis or lymphoma. So as a routine, yes, but not specifically because you don't expect the stomach not to be distensible.
Yes, sir.
And you said extent. What do you mean by extent?
So proximal and distal extent, sir, along and also the circumferential extent, sir.
Which is most
So I want to
important?
know whether it is circumferentially involved, sir, and I want to know what is the proximal and distal extent of the tumor. The proximal extent is more important.
Yeah, the most important is the proximal extent, especially if the tumor. One is that whether the tumor is at the lesser curvature or greater curvature,
Yes, sir.
whether it is at the anterior wall or a posterior wall. Why curvature is important? Because if the growth is at the greater curvature, you know that you have a big length of the stomach available, and margin usually would not be a problem.
Yes, sir.
Unless the tumor is at the fundus.
Yes, sir.
On the other hand, if the tumor is at the lesser curvature, depending on the shape and size of the stomach, even a small growth may be a problem because you want proximal 5 centimeter margin. And
Yes, sir.
if there is no 5 centimeter margin between the GE junction and the proximal extent of the tumor, you may have to resort to a total gastrectomy.
Yes, sir.
So proximal margin is the most important. Distal doesn't really matter.
Yes, sir.
Because distal usually is not a problem.
Yes, sir.
Anterior and posterior also important, but not that important because if the tumor is posteriorly located, there are more chances that pancreas may be involved, but that you would see on imaging in any case. So
Yes.
most important thing, which unfortunately most endoscopists do not report, is the distance of the proximal edge of the tumor from the GE junction. And that is one advantage that if you do your endoscopy yourself, that is the thing which you will look for.
Yes, sir.
Okay, you said multiple biopsies taken. Why multiple biopsies?
Sir, to increase the positivity of the tumor, sir, ideally 6 to 8 biopsies are recommended, sir.
Mm-hmm.
So that not just the superficial biopsies are taken, but good sample is taken, sir.
So the moment you say 6 to 8 biopsies are taken, I will ask you from where these biopsies are taken. So your answer should be complete in the first go. In the first instance, you should say that it is advisable, it is preferable, it is recommended to take 6 to 8 biopsies, at least 2 from each quadrant, preferably from the edges of the tumor, not from the center of the tumor, where the normal mucosa is meeting the abnormal mucosa. If you say that, I don't have to ask any counter questions.
Yes, sir.
So whenever a question is asked, try to answer the complete question in the first go itself so that you don't generate any counter questions. Aim in the exam should be that the examiner should ask a new question every time, not a counter question.
Yes.
Okay. What does the biopsy show?
Biopsy shows features of adenocarcinoma, sir, diffuse type.
Suppose the biopsy was negative.
Yes, if the biopsy was negative, I would discuss with the endoscopist, sir, regarding the quality of the biopsy that was taken, and I would definitely plan one repeat biopsy, sir, deep well biopsies of more representative samples.
What do you mean by deep well biopsy?
Sir, biopsy on biopsy, sir. From the margin, you take a chunk, and then from the same site, you again take a deeper biopsy, sir. So that not just the mucosa, but the deeper tissues are also included.
Is there any other method to increase the yield of a second biopsy?
So you can perform enhanced endoscopy, sir, or like a narrowband imaging or confocal imaging, sir, or you can go for an endoscopic ultrasound guided biopsy.
Suppose you don't have endoscopic ultrasound, you don't have narrowband imaging. Does it increase the yield of biopsy?
No, sir. It can give us guidance from where we can take, sir, especially if the mucosa is normal based on the vascular pattern we can identify which areas can be taken for
Yeah,
that.
so narrow band imaging only gives you a microscopic picture of the mucosa to show
Yes.
you the transition from normal to abnormal. It only helps you to localize the area from
Yes.
where to take the biopsy. The yield of biopsy will depend on the depth of the biopsy.
Depth of the biopsy.
So
Yes.
one way to increase the depth, you said, is the well biopsy, which means
Yes.
a biopsy on biopsy. Take at one place, and at the same place, quickly before the bleeding obscures the site, you take a deeper biopsy.
Yes.
So that you get into the depths of the wall
Yes,
of the stomach. Any other method? Any gadget? New gadget? So check with your gastroenterology colleague, but I think that now there are these biopsy forceps which are bigger in size. So basically they are punch biopsies, isn't it?
Yes.
So
Yes,
the
sir.
punch which they take is, there are forceps now which have a bigger punch or a deeper punch. So you can get, in a single attempt, you can get a deeper tissue. Okay, second biopsy also negative. What is the commonest reason of biopsy being negative?
Sir, so if the biopsies are not representatively taken, sir, either they are taken from the center of the lesion, or the dead slabs, or if the biopsies are very superficial, including only the mucosa of the colon.
Yeah, even if the biopsy is superficial, only mucosal, the tumor is mucosal, so it should be positive. The commonest reason is that you have taken it from the central part of the ulcer or growth, which is usually necrotic.
Yes.
So you just get necrotic tissue, you don't get the tumor tissue. That is the commonest reason for a biopsy being. Okay, second biopsy also negative.
Yes.
It happens, isn't it?
Yes.
So what do you do?
So then I would either try for an US guided biopsy, sir.
Not available, she can't afford.
Yes.
The husband says, Doctor Sahab, jaise bhi hai, please manage. I can't afford.
Then we may go for other types of investigation, sir. I may get a tumor markers done, sir, or we can get a PET-CT if the high clinical suspicion is there.
Which tumor marker?
So we can do a carcinoembryonic antigen or CA72.7.
You already did it. It was normal.
Yes. Yes, sir.
And does it help in diagnosis?
No, sir. They are more of prognostic, sir, with low sensitivity and specificity.
So what will you do?
We can consider for PET scan also, sir. If there is high clinical suspicion of malignancy, it may give a guidance.
Does it give you the tissue diagnosis?
No, sir.
So what will you do? Suppose it is avid, suppose it is not avid. How does it make a difference?
So if it is not avid, means it is suggestive of a poorly differentiated cancer.
So how will it change your management, whether it is avid or non-avid? You do an investigation only if it helps you in management. Otherwise, it is of no use.
Yes, sir.
So the answer is that based on the clinical and more importantly, the endoscopic picture is highly suggestive of malignancy. It doesn't look like a benign ulcer, isn't it?
Yes, sir.
The answer is that without a tissue diagnosis, obviously, I cannot give chemotherapy. No oncologist will give chemotherapy. But after evaluating the disease, which as we would discuss would be with imaging, CT, and maybe PET, if there are no features of dissemination, on high suspicion of malignancy, I would treat it as malignancy.
Yes, sir.
So in such situations, surgical resection, like malignancy, is appropriate, of course, after counseling and after documenting that you are going ahead without a tissue diagnosis with a strong endoscopic and maybe imaging suspicion of malignancy. If it turns out to be benign, good. But you can't do a conservative management or a conservative surgical procedure thinking that it is benign and then having a diagnosis of malignancy, because then you have lost the opportunity.
Yes, sir.
The answer in such situations is that you would proceed based on clinical, radiological, endoscopic, high suspicion of malignancy and treat it like malignancy.
Yes, sir.
That is what the approach will be.
Yes, sir.
Okay. Since we have very little time, do we have an image?
Yes, sir. We have the CT scan, sir.
Let's have a look.
Actually, sir, outside someone has they had done a PET CT, sir. PET CT, sir.
Show us the representative.
Are you able to see, sir?
Yes, yes, we can see. But we are seeing these multiple
Yes, sir.
images.
Yes, sir. These are the upper chest, sir. And coming down here, we are able to see the esophagus, sir.
So what investigation was done for her?
Sir, outside they have done a PET CT, sir.
Would you agree with this?
No, sir, I would do a CT with oral contrast, sir.
Why not PET CT?
PET CT, upfront, there is no indication for PET CT in a CA stomach, sir. If it was a CA esophagus or G junction, we may have done, sir. But for stomach, there is NCCN guidance. There is no standard indication for PET CT, sir.
Why? Why not? Why PET is not a standard recommendation for stomach?
Almost 20 to 30% of the stomach may be non-PET diabetic, sir.
Why?
Because they're poorly differentiated, sir.
Is it the differentiation? Is it something else? It's because they are mucin secreting. Mucin secreting tumors are usually not avid.
Right, sir. I'll scroll further, sir. This is the esophagus, sir. Now we are coming to the G junction, sir.
We are seeing only the static image.
Are we able to see, sir? Is it scrolling now, sir?
Not yet. Okay, I think you give us the report, describe. Just tell us what did the CT show. Yes.
Are we able to see the report, sir?
Yes, yes, yes.
The PET CT report, sir, which is showing a linear area of increased FDG habit concentration, noted in ill-defined, excavated, ulcerated wall thickening involving the incisure of the stomach, extending slightly to the antrum, approximately for a length of 3.78 centimeters, maximum thickening of 2.6 centimeters with SUV max of 5.89. There is significant luminal narrowing at the level of the lesion, seen as a thin strip of contrast passing through. But there are no obvious FDG or enlarged abdominal lymph nodes.
So what do you make out of this report?
It is an FDG avid growth involving the incisure of the stomach, lesser curvature of the stomach, sir, which is causing some luminal narrowing.
Don't repeat what you have already described. What do you make out?
So CT wise, it looks like a T310 tumor, sir.
How can you say T3? CT can only say whether it is T4 if the adjacent organs are involved.
Yes, sir. There is no.
You should say that it shows a localized, possibly resectable, or maybe definitely resectable tumor of the distal stomach. That's all, isn't it? With no lymph nodal or distant metastasis.
Yes, sir.
So this is the kind of report where even if the biopsy is negative, you can go ahead because it is a eminently resectable lesion.
Yes.
So it was resectable. Why did she receive neoadjuvant treatment then?
Actually, the treatment was also given outside, sir, and she was
referred. You would have done the same thing or no?
So there are no lymph nodes positive, sir. But imaging wise, it looks like T3, sir, and it is a diffuse variety, sir, in a young female.
So on which ground are you saying neoadjuvant treatment is? What is the reason for giving neoadjuvant treatment here? Age, diffuse variety, T-stage, what?
Sir, age also, sir, young female with a diffuse variety tumor with T is T3, sir. It's not involving other. It is otherwise operable, sir.
So indirectly, I am asking why or what are the indications of neoadjuvant chemotherapy in a resectable CS stomach? This is a resectable CS stomach,
Yes, sir.
upfront resectable.
Yes, sir.
So what is the reason or what are the advantages of giving neoadjuvant treatment?
Yes, sir. CS stomach is otherwise considered as a systemic disease, sir. Neoadjuvant therapy will take care of micrometastasis as well, sir. Also, it will help in testing the tumor biology, sir. Especially because it is a diffuse variety in a young female, it may avoid an uh, 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 total gastrectomy, sir. Also, it will improve the resectability and R0 rates.
So these are general points for neoadjuvant treatment. I think the answer is that it has been shown that even in resectable CS stomach, if you give neoadjuvant treatment, the chances or the risk of local recurrence will be less and disease-free survival will be more. So that is the indication. The others are theoretical advantages that all cancers are systemic to begin with. There are micrometastasis. You can give chemotherapy to well vascularized and well oxygenated tissues where there's post-op, there may be delay or tissues may not be well perfused. So those are all theoretical advantages.
Yes, sir.
Okay, so in some cancers now it has been established that even if the disease is primarily resectable, that doesn't hold true for pancreas. In pancreas, there is still debate and controversy.
Yes.
But at least in stomach, at least in rectum, it has been shown. So does it mean that all resectable CS stomach should receive neoadjuvant chemotherapy?
No, sir. There are few indications for upfront surgery also, sir. For example, if the patient is having gastric outlet obstruction or the patient is having bleeding or if it is a very early tumor.
Gastric outlet obstruction you can still take care of by placing a stent and then give chemotherapy. So that is not an absolute kind of indication for upfront surgery. It used to be, but now it is not. The only cases where a resectable CS stomach would not or should not receive neoadjuvant chemotherapy is an early lesion. So T1, some people would say T2 with no N0 status, good biology of the tumor based on histopathology and all those things. So T3 definitely, T1 definitely not, T2 plus minus.
Yes.
And T stage cannot usually be indicated by a CT scan. You need an endoscopic ultrasound. So if you are going to do upfront surgery, that means you are not going to give neoadjuvant treatment, then an endoscopic ultrasound is usually a must for better delineation of T stage and for documenting that there are no enlarged perigastric nodes. So to select cases for no neoadjuvant treatment, and next step is to select cases for endoscopic management, very early lesions. You have to have an endoscopic ultrasound. Otherwise, in large majority of cases which present to us with symptoms, there is no place, there is no role for endoscopic ultrasound, whether it is esophagus, whether it is stomach, whether it is rectum. Endoscopic ultrasound is usually not required in most of our cases. Okay?
Yes, sir.
So I think if you want, tell Dr. Anand that we can continue with the surgical management of this patient in the next or whenever you are available. Coordinate with Dr. Anand and fix up a class for management of this case. Okay?
Yes, sir. Yes, sir.
Any question from any of the students? Anything? Okay, then we will close. Thank you. Thank you, Gaurang. Thank you.
Thank you, sir. Thank you so much.
And yeah, students, please send me a mail, vkkapoor.india@gmail.com. Write stomach in the subject of the mail. So I'll send you the chapter on stomach. Thank you.
Thank you, sir. Thank you so much, sir.